Hello. Good afternoon, everyone. Ayas and I will present a topic about pleural effusion, one of the huge topic in respiratory problem. So I managed to get one case to present about pleural effusion. As we all know, there's a lot of etiologies of pleural effusion. So this is one of the etiologies and how we manage in respi department. I proceed with the case terus lah. So this is a case. Patient details is Mr. JTL. He's a 44 years old gentleman, ideal independent, chronic smoker more than 30 packs years, alcohol drinker 3 to 4 times per week. Completed this time completed vaccine 2 times Pfizer. He works as pembantu takbir at Wisma Pertanian Sabah and married with 4 children. Family history, there's no family history of malignancy. There's no other significant hereditary disease. His underlying is actually DM hypertension and dyslipidemia under KK penampang follow-up on metformin, felodipine, and simvastatin. So this patient, he initially presented to Hospital Queen Elizabeth II with chief complaint of reduced effort tolerance for 2 weeks and worsening past few days before presented to
Okay, I think they got disconnected. Just let me get in touch with the presenters again.
Hello?
Okay, yeah, we can hear you now, Hanatia.
Okay. Wait,
We heard you until past medical history before.
So so the one is underlying is DM hypertension and dyslipidemia under KK penampang. He initially
Hanatia, sorry, can you share your screen? Yeah.
The slides are.
Yeah.
What happened? Okay.
Okay.
So patient initially presented to Hospital Queen 2 with chief complaints of reduced effort tolerance for 2 weeks and worsening past for few days. Also associated with dry cough, loss of weight for 5 kilo in 1 month and in duration and loss of appetite. Associated with a PND and autopnea for 2 weeks. Otherwise, no night sweat. He denied TB contact and history of TB. No fever as well. So in ED assessment, initially in ED assessment, vital sign was okay. Her typo bit heart rate was normal actually. RR is 24 with saturation 96%. Lung assessment noted there is reduced air entry over the right side with stony dullness. So they did chest X-ray in ED Queen 2, noted right pleural effusion with bedside scan. Echo is good contractility, no regional abnormality, no pericardial effusion, noted right lung pleural effusion. Otherwise, patient was comfortable that time under room air. So patient was admitted to male extension ward and started with augmentin and azithromycin. So this is the initial X-ray when patient initially presented to Hospital Queen 2. So noted there is the usual pleural effusion at right lung. Left lung looks quite fairly clear. So in medical extension ward, so on examination, chest is tracheal, is central, right lung reduced air entry, with left lung reduced air entry, with dull on percussion. Left lung is good air entry with no added sound. CVS is no murmur. There's no palpable lymph node, no clubbing, no joint pain. So in extension ward, not done diagnosis pleural tapping done on the 9th of August 2000 last year lah. So done under ultrasound guided. So ultrasound guided showed multi-loculated pleural effusion. So we drained about 350 of serous fluid. So pleural fluid stand for biochem, noted exit with PF protein 45 and serum 52, LDH 1743, serum is 240. So this biochem fluid effusion investigation shows exudative fluid effusion with LDH very high, 1743. There's no pH and glucose was sent during this time. Other pleural fluid investigation such as gram stain, culture, and TB PCR was negative. So because the LDH very high, it was a chest tube was inserted on 11th of August last year, and post chest tube insertion X-ray almost similar with pre chest tube insertion. So they query there's a lung mass there. So initially planned for CC thorax through lung malignancy, but and the chest tube drain noted from day 1 to day 3 noted 500 drain, 300 and 175 hemoserous fluid. This is the patient. I was actually discussed with RESPI, right, whether patient can do pleuroscopy or IPFT, the intrapleural analysis therapy, and case was transferred over to RESPI ward for further management. During this time, it was during the August 2021. There's no RESPI team go to Quinto to assess patient to do proper examination of the patient. So patient was taken over to RESPI ward. This is the investigation done in Quinto. Noted the HB is 12 and total weight is 16, NC is 14. CRP is 86. RP looks like normal, no hyponatremia. LFT is very normal also. Calcium is 2.26, no hypercalcemia. Sputum FB times 3 was shown no AFB. Sputum culture, no growth. Also with the blood culture, also no growth. When patient was transferred to Queen Hospital, Queen 1, RESPI ward, pleural fluid investigation ADA is still pending, but later on you will let the PF result ADA is 23 which is low. MTB culture also negative, no MTB. TB PCR was negative. Cytology shows smear, shows scattered mixed inflammatory cell and acellular debris. No malignancy cell seen. So this is X-ray when first time in Queen 2 inserted chest tube. There's not much different compared to the first time patient admitted. So in RESPI ward, chest tube was still inside fluctuating. So regular flushing was done with normal saline in the ward at 20 cc. However, chest tube drain noted very minimal fluid for a few days. The first 2 days, there's no fluid and 125 and 100. But if we minus with the drain that we do, the net drain is very minimal only. So in our ward, bedside ultrasound done and noted there's a multi-loculated right pleural effusion with raised right hemidiaphragm. It was unable to visualize the lung clearly. So no obvious mass or so, and no window for pleuroscopy. So that time, our impression was complicated pleural effusion. So we proceed with intrapleural fibrinolytic therapy on the 18th of August. So given 250 units of streptokinase and 5 mg DNase. So this is the X-ray when patient was first arrived to RESPI ward on the 15th of August. And this one, after a few days, there's very minimal lung re-expansion noted on the 17th of August. So hence we decided for IPFT, proceed with IPFT for this patient. Oh, so this is basically our guideline SOP for intrapleural fibrinolysis therapy. The purpose for IPFT basically consisting of streptokinase and donase, which is a DNase, it has been shown to be effective treating complicated pleural effusion and empyema. The intrapleural installation of this agent improve the drainage by breaking down the septation and also decrease the fluid viscosity, therefore improve the treatment outcome and prevent the need for surgical intervention. So treatment should be used in addition to standard management of pleural infection, including appropriate antibiotics, effective pleural drainage by chest tube, and management of any predisposing factors. This is roughly the indication. There must be a pleural infection as indicated by purulent pleural effusion, or the pleural fluid positive for bacteria or gram-stain, or the culture positive, or there's the exudative pleural effusion with pH less than 7.2, glucose less than 2.2, and pleural LDH more than 1,000. And there's no clinical improvement despite of 12 to 24 hours of effective pleural space drainage, and evidence of persisting localization of effusion as seen in pleural ultrasound, CT thorax, or chest X-ray. So as this for this case, noted there's a very minimal improvement, regular draining, regular flashing done in respi ward. So after the first IPFT done, noted the drain increased to 900 mils per first day. So the second day, we proceed with second IPFT on the 19th of August. So the second day drain is only 350. After a few days with regular flushing, we noted we did a bedside ultrasound scan on the 20th, noted able to visualize lungs better, and noted significant reduce of amount of previously seen fibrin and no longer seen lung. So chest tube was still kept for 2 more days with regular flushing with normal saline. So the chest drain is 150, reducing to 75 mils. And finally, chest tube removed on 23rd of August 2020 after minimal drain noted. So this is the comparison after the IPFT done. Noted there's a very remarkably improved of the lung marking here compared to the previous chest X-ray when patient initially arrived to respi ward. So for IPFT, you will usually do a baseline spirometry before and also usually 1 week after the IPFT. But this one, first spirometry done, noted the FEV1 1.69 liter and FVC is 2.3 liter, which is around 60%. Then this is the 23rd after five days. Noted is about the same but FEV1 increased a bit to 1.7 liter with 62%. And there's another lung function test was done after about 2 months after the IPFT. Noted there's much improved FEV1, 2.34 liter with 79%. The FVC is 3.01 liter, 80%. Almost normal spirometry. So this is spirometry when the X-ray when we saw the patient in the clinic. So patient was discharged well after we removed the chest tube and complete the antibiotic for total of 6 weeks. So this is X-ray of this patient. Noted there's a minimal pleural thickening left on the right lung. So during the respi clinic review, patient was completed 6 weeks of antibiotic augmentin, and patient currently well with no active complaint with MRC grade 0 to 1. No cough, no SOB, no chest pain with good appetite, no loss of weight. Gaining weight, currently weight is 77 kg from 70 kilos. On examination, patient not tachypneic, red lower zone, still reduced air entry, and we did as outpatient CT thorax just to rule out any risk of malignancy for this patient because it's active smoker also. So impression from the CEC thorax done in December is right pleural hyperdensity with adjacent subpleural consolidation with elevation of ipsilateral hemidiaphragm, as described likely to be pleural thickening rather than residual effusion. Chest X-ray is similar to previous chest X-ray, where we've been monitoring the X-ray. The X-ray has been stable right pleural thickening. We did advise this patient for decortication, but patient not keen for surgical intervention at the moment because patient also feel asymptomatic, MRC grade 0 to 1. He able to do jogging as well during the clinic review. The fluid effusion has been stable all this while, but we're still monitoring the patient with radiological monitoring for this patient. So this is the case study, a bit of IPFT therapy. There's two largest and adequate powered randomized trial, MISS, multicenter intrapleural sepsis trial, MISS-1 and MISS-2. It demonstrates there's a clear, from this trial, it demonstrates a clear lack of utility of use intrapleural prebiotic alone compared to placebo. However, in MISS-2 trial, noted there's a largest positive noted there's a clear and clinically important benefit, the use of combined tissue plasminogen activator and also the DNS intrapleurally. This benefit includes radiological outcomes, reduction in hospital length of stay, and need for surgical referral. So combination of TPA and also DNS has shown great promise and also expedite the drainage of patient of empyema and also complicated pleural effusion, with reported cure about 90% of patients without requiring this surgery. However, the administration of TPA and DNS is relatively labor intensive, as combination is generally given twice daily or once daily, and each part component given separately via the chest tube about 2 hours apart. Complication is usually spent and commonly can be controlled by adequate analgesic, and also bleeding is about 2%. So this is the case study for this for today's CME. Then proceed with the theory part to Dr. Ayas. Please stop.
Okay, hello, good afternoon, everyone. Thank you, Dr. Hanafia, for the case presentation. So I'll move on to the theoretical part of pleural effusion. So this is the list of our discussion for the theoretical part. So as we all know, the pleural effusion is one of the common medical problems with a variety of possible causes. So to tackle this problem, we need a systemic approach so that we can minimize the unnecessary invasive investigation, as well as we want to avoid the need of repeated therapeutic aspiration when possible. So approximately about 1.5 million of patients diagnosed with pleural effusion in the US each year. And from this number, the leading cause of pleural effusion is a congestive heart failure, and followed by pneumonia as the second most common cause. Then malignancy is the third leading cause with the incidence of 200,000 cases each year. However, this malignancy is still the second most common cause in the age group of patients of more than 50 years old. Okay, and then TB is the most common, most important cause of a pleural effusion in a developing country, especially for us in Sabah. We have a high incidence rate of TB. So high index of suspicious will lead to early diagnosis and intervention for the TB. Okay. So a little bit of epidemiology of a TB in Sabah. So there's a study done between 2012 and 2018 where they reported as about 33,193 cases of TB reported in Sabah only. So while Sabah state is only, the population is about 10% of total country population, but the reported case for TB is around 20 to 30% of all total TB cases in Malaysia. So this previous study said that TB epidemic in Sabah is mostly because of lack help seeking and also limited access to the TB care. Okay, So move on to the pleural effusion. So what happened in pleural effusion actually is when the rate of development, rate of production is more than the rate of resorption. So the effusion, it can be exudative or transudative according to the light criteria. So normally in the pleural space, there will be a very minimal fluid which help in our lung surface to glide between the thorax, which each respiratory cycle. So usually there will be around 15 mils per liter fluid. 15 mils per day of fluid will enter the potential space, and the fluid will be removed via the lymphatic drainage of the parietal pleura. So when the pleural effusion occurs, we can divide them into two. Is it transudative or is it exudative effusion based on our light criteria over here. So it's including the ratio between the pleural fluid protein and the serum protein, pleural fluid LDH and the serum fluid serum LDH, and also when the pleural LDH is greater than the 2/3 of the upper limit for the normal serum LDH. So this criteria is very important for us. So even only one criteria are considered exudative diffusion already. So for transudative diffusion, what happens here is when there is a increased hydrostatic pressure and reduced oncotic pressure. So there will be a fluid accumulation over there, or it can occur due to the alteration in the lymphatic drainage. So our BTS guideline, they divide very nicely already the common cause, very common cause, less common cause, and rare causes of the transudative diffusion. So very common cause of transudative diffusion is usually because of the heart failure, mainly left ventricular failure, and also liver cirrhosis. And the less common cause is hypoalbuminemia, those patients with peritoneal dialysis or even hypothyroidism and nephrotic syndrome. And then rare causes like constrictive pericarditis, MEC syndrome is also cause of a transudative diffusion. Then move on to exudative diffusion. Here is the capillary bed itself already a disease. So increased permeability, fluid leak. So the fluid will be accumulated in the pleural space. So for this category, the most common cause is malignancy, parapneumonic effusion, and also PB. Then the other possible cause including PE, autoimmune related pleurisy, and sometimes drug induced. And then if we move on to the exudative, actually we can categorize them into a very broad category like infectious cause, malignancy related. There are so many causes of exudative diffusion. Then if we focus over here, the causes of a lymphocytic pleural diffusion is rarely done in our setting, the pleural fluid cell count. But if we do this one and we saw there's a lymphocytic pleural diffusion, so it actually will narrow down our differential diagnosis into this list of diagnosis, like mainly malignancy, TB, and also cardiac failure. And then this is the list of medication that are commonly related. Case reported that this medication might cause exudative diffusion in some patients. So for the clinical assessment, clinical history and physical assessment of the patient itself will guide us to the early differentiation between exudative and transudative diffusion. So the clinical assessment alone will be capable of identifying transudative diffusion. So in an appropriate clinical setting, for example, like a case of a left ventricular failure, when they presented with effusion, that effusion do not need to be sampled unless you are suspecting some atypical features or the patient itself failed to respond to your treatment. And then we should get a patient's drug history also, although it's uncommon, but that I previously showed you the list of medication have been reported cause exudative pleural effusion. And occupational history, for example, like asbestos exposure is also possible cause of effusion. And then approximately about 75% of patients with PE, they tend to have an effusion, and then usually the pleural effusion will occupy about less than 1/3 of the hemithorax. And then the level of dyspnea actually is out of proportion to the effusion size. So in this situation also, the pleural fluid analysis is usually unhelpful to diagnose the PE. So again, it needs a high index of suspicion for us to avoid the main root of the diagnosis. Then for the symptoms wise, usually in a pleural effusion, they will come into us with a dyspnea, cough, and pleuritic chest pain, and also exertional dyspnea. Then the typical finding from our physical examination, usually absence of breath sound on the affected side, dullness on percussion, there's the absence of decreased tactile parameters, and also decreased vocal transmission. And then we need to pay attention on the underlying medical illness, for example, like a congestive heart failure, underlying liver cirrhosis, renal failure, or previous history of malignancy, and as well as autoimmune disease, because it may associate with a pleural effusion. And then those patients came in with fever or cough with a purulent sputum. This may suggest an infective origin. And then those patients who are more than 50 years old, chronic smoker, came in with a constitutional symptoms with or without his family history of malignancy, we need to suspect of a malignancy origin. So BPS guideline, they already give a very good diagnostic algorithm for the unilateral pleural effusion. So starting with the history, clinical examination with the plain chest X-ray. Then from this information, we categorize the patient, whether or not this patient show you transudative features or you're suspecting of exudative origin. If it is transudative, then you may treat what could be the possible cause, then monitor the progress. If it is resolved, then don't need to look up further. Just treat the underlying cause. And then if it's not transudative, then you may proceed with the pleural fluid aspiration, send for the basic investigation, then review back the pleural fluid analysis and see where this pleural fluid sampling categorized into transudative or exudative. Then you may treat according to that criteria, to the category. So for those patients who you cannot achieve the diagnosis, even the pleural fluid sampling also you couldn't find the exact diagnosis, then we might need to get early CECT thorax. Okay, then the CECT thorax, from there, our finding, we will move on further into the invasive investigation. A few choice of invasive investigation we have in our setting. For example, in our recipe, we will provide a fluoroscopy. And then if our CT imaging shows the evidence of malignancy, then we might get a CT guided biopsy by the IR team also. And then from that, if we already identify the histological diagnosis, then we can treat accordingly. So the initial diagnosis of pleural effusion, starting with a plain radiograph, we need the posterior and inferior chest X-ray should be performed in a case of a suspected pleural effusion. So only about 200 cc of pleural fluid will show abnormality on the chest X-ray. And then it takes only at least 50 cc of pleural fluid to cause a blunting of costobranchic angle. And then ultrasound will help us to confirm the presence of pleural fluid. And then it significantly increased the likelihood of a successful pleural fluid aspiration. So try our best not to do a blind pleural fluid aspirate. Do get ultrasound guidance to do the pleural aspiration. So it actually helps to reduce the risk of iatrogenic injury. And then it also had high sensitivity to detect a pleural fluid septation so that we can suspect a complex pleural effusion. And then other further diagnostic imaging we have is a CT scan. It must be a contrasted CT scan. It should be performed before full drainage of the pleural fluid, because the pleural abnormality will be better visualized with the presence of the pleural fluid. And then CT are also helpful for us to diagnose the presence of an empyema or lung abscess, and also helpful in detecting the features of a malignancy. Other choice of a further investigation is MRI. MRI are rarely done in our setting actually, but maybe can be considered for those patients who are contraindicated to the contrasted CT. And then PET scanning so far has no role in our investigation. So this is our ultrasound finding. Over here, you can see there is a loculation of a pleural effusion. And then this is showing you a complex pleural effusion. And then here is a plankton sign. There is a look like a debris pleural effusion. So it's showing you a complex effusion. Then over here is a nodularity on the diaphragmatic surface, so suspecting some of features of malignancy. then this one is a thoracic spine sign. In the case of there is no effusion, you couldn't see a spine sign. The spine sign is stopped at the level of diaphragm. But in the presence of the effusion, you can see the continuity of spine signs towards the effusion. Okay, so for the pleural fluid aspiration, this is our primary means of evaluating pleural fluid. So it will be helpful in the next step of a further investigation for the patient. So our BTS guideline, they provide sampling collection. Usually for the biochem, pleural fluid for biochem, only need about 2 to 5 cc of pleural fluid in a plain container. Then should be sent together with a serum protein and LDH for us to apply the light criteria. Then for the pleural fluid CNS, it is recommended to use a CNS bottle to increase the likelihood of catching the organism, and then to avoid the sampling error. And then for the cytological examination from the pleural fluid, it is recommended to send as maximum volume as possible, usually about 40 to 50 cc of pleural fluid. And then other investigation will be sent accordingly, depends on your clinical judgment. For the pH, pH usually we will send if we suspecting of in a case of a non-purulent pleural effusion, then you suspect a possible of a pleural infection, then you might want to send a pH to see if there is any pH acidosis. Usually pH less than 7.3 is a suspicious of infective origin and also malignancy origin. And then for the glucose, usually is related to the autoimmune pleurisy. And then AFD in the case of a suspicion for PD, but usually for AFD, MTB-CNS, we send as our routine investigation in our setting. And then for hematocrit, in the case of you want to differentiate is a hemoserous or is hemothorax, then you might want to send hematocrit in EDTA tube. If the result shows more than 50% of hematocrit, then it's high likely it's a hemothorax. Then the characteristic of the pleural fluid is also important for us. While aspirating, we need to identify the character of the pleural fluid. Usually it's very pungent smell, it's more towards an anaerobic empyema, should be suspect. If there is any presence of food particles, then esophageal rupture should be suspected. And then if bile stand, then think of a colothorax with biliary fistula. And if milky, then it can be chylothorax, pseudocholothorax, as well as the empyema. Then anchovy sauce like fluid, likely is a ruptured amyloidic abscess. And then if we send for the cytology sampling, usually the reporting will be inadequate, no malignant cell seen, atypical cell or suspicious of malignancy, or its malignant features. So if it is adequate, meaning they couldn't see any presence of a mesothelial cell, or they only see a degenerate cell presence. And then if there is no malignant cells seen, then the sampling is adequate without evidence of malignancy. If they reported as an atypical cell, maybe inflammatory or malignant origin, so we need to send for further investigation. If there is a suspicious of malignancy, usually they will show an occasional cell with malignant features, but it is not definitely malignant. Then if malignant, then it's showing you there is some presence of malignant cell in the sample. Then the pleural fluid color is also will guide us in our diagnosis. So if the color of the pleural fluid presents as a pale yellow, usually it's a transfudative. And then if it is bloody, then we should suspect of a malignancy or related to PE with pulmonary infarction. If it is milky, again, it's related to chylothorax. And then if it is yellow-green, suspect of some rheumatoid pleurisy. Then this one already mentioned just now. And then additional investigation for the pleural fluid investigation is ADA. This one is one of the most important additional investigation for the pleural fluid. Its level is significantly raised in most tuberculous pleural effusion. A meta-analysis from BTS shows 63 studies on the diagnostic use of ADA confirm a sensitivity of 92% ADA also can raise in the case of lymphoma, so it will increase the possibility of a false positive. So when you aspirate a pleural fluid sampling and you saw the features is a pus-like material, so avoid sending ADA because the result will be high. And then it may also raise in a rheumatoid pleurisy and also occasionally in a malignancy. So usually the level of ADA typically greater than 35 to 50 is a tuberculous pleural effusion. Okay? And then for the tumor marker, serum tumor marker and pleural fluid tumor marker currently have no role in the pleural fluid investigation. However, the mesothelin may have a promising diagnostic characteristic. So it's actually a glycoprotein tumor marker present with a higher concentration in the serum, both serum and pleural fluid in the case of a malignant mesothelioma. So if it is positive, then it is highly suggestive of a pleural malignancy. So this one is actually helpful in the case of we want to clarify the Okay, then for the amylase, usually if you have related pleural effusion, then you can send a pleural fluid amylase. Usually this one can be sent together with the pleural fluid biochem. They will run together with the sample. Then for the cell count, usually for our setting, they are not routinely done the cell count, but we can maybe request if you want, if we are suspecting, if you want to work up further on the pleural fluid. So there are a few causes for lymphocytic pleural effusion. Maybe it's a malignancy and TB but any long-standing pleural effusion tend to be populated by the lymphocyte. And then pleural malignancy, cardiac failure, and tuberculosis are most common cause of a lymphocytic predominant pleural effusion. And then for the connective tissue disease related pleural effusion, most commonly is rheumatoid arthritis and SLE. So the rheumatoid arthritis, most chronic pleural effusion secondary to rheumatoid arthritis. Usually, if we're suspecting this origin, we can send a glucose level. It will show a very low glucose level around less than 1.6 mmol per liter. Then rheumatoid arthritis related pleural effusion usually common in male, although the disease itself are common in women. Then for the SLE, at the moment, the pleural fluid anti-nuclear antibody should not be routinely measured because it only reflects the serum level, so it will be unhelpful for the diagnosis of this condition. And then in the case of a chylothorax or pseudocylothorax, usually our sampling will appear milky. So if we suspect a chylothorax, we should send the sample to run for the cholesterol and triglyceride level. Occasionally, the empyema also will be sufficiently too big, so it might confuse you with a chylothorax and empyema. So to distinguish these two, you can send for centrifugation. So the empyema will usually leave a clear supernatant, while the chylos will remain milky. Then in this condition also, you need to differentiate between two chylothorax or pseudocylothorax. So usually pseudocylothorax is due to the accumulation of cholesterol crystals. And then a true chylothorax usually will show you a triglyceride level of more than 1.25. And then in pseudocylothorax, it will be absent. But pseudocylothorax will have a high level of cholesterol. Then chylothorax usually will be very low level of cholesterol. Then chylothorax usually happen in a trauma or malignancy, and then pseudocylothorax usually related to the TB or rheumatoid arthritis. So move on to the investigation. We have a few choices. We have percutaneous pleural biopsy. We have pleural thoracoscopy, video-assisted thoracoscopic surgery or bronchoscopy. So for the percutaneous pleural biopsy, usually will be done by our IR team. This one, if your CT images shows there is a presence of mass, then you want to identify what could be the possible mass is this, and is it benign or malignant? Then you can send for the CT guided biopsy done by the IR team. And then for our part, we will do a thoracoscopy because of fluoroscopy. So this is our investigation of choice in an exudative pleural effusion, where your diagnostic pleural aspirate is inconclusive or you are suspecting some malignancy, then we can proceed with this fluoroscopy. So this one usually will be done under local anesthesia. Then after the procedure, usually the patient will be put on chest drainage. Then we will drain out the pleural fluid, and then we will reassess. And then if there is a complete re-expansion of the lung, we might proceed with the pleural disease if indicated. And then for video assisted thoracoscopic surgery, usually will be done by CTS team. And then for bronchoscopy, routine diagnostic bronchoscopy should not be performed in an undiagnosed pleural effusion. But we can consider bronchoscopy in a case of a presentation with hemoptysis, or there is a clinical or radiological feature suggestive of bronchial obstruction. So if bronchoscopy is necessary, we need to drain out the fluid first before we perform the bronchoscopy for us to adequately examine without presence of the extrinsic airway compression caused by the pleural effusion. So in a case of persistent undiagnosed effusion, even after a complete investigation, including the invasive investigation, significant number of patients with pleural exudates diagnosed.
Ataupun yang boleh transfer dia macam di hospital kita, sebab dia ni memang di hospital kita tu.
And no specific diagnosis can be made. A retrospective study of a 75 such patient found that only 8.3% of them turned out to be malignant over a 2 years follow-up period. Then majority of the patient with a non-specific uritis, about 91.7%, followed benign course. Then they achieve a spontaneous resolution. And then in patients who are not fit enough to undergo the thoracoscopy, it is sensible to reconsider the diagnosis with a specific treatment, for example, like TB, pulmonary embolism, lymphoma, or chronic heart failure. A considerable number of undiagnosed pleural effusion in this category are due to the malignant process. So watchful waiting may be appropriate in the management of this setting. So in a case of malignant pleural effusion, we have a few management options, but to determine the option, usually we will need to see several factors, including the symptoms and performance status of the patient, what could be the primary tumor types, and also response of the patient to the systemic therapy, degree of lung expansion following the fluid drainage. And then malignant pleural effusion often most effectively managed by complete drainage of the effusion, and then followed by the instillation of the sclerosant to promote pleural disease, so that we can prevent the recurrence of the effusion. Because massive massive from a malignancy cause. So the option of the management usually will be observation. This one are recommended in those patients with asymptomatic and the tumor type is known, and then the patient responds to the systemic therapy. And then for the therapeutic pleural aspiration, usually treated with aspiration alone, there will be high risk of recurrence. So it is not recommended in those patients with life expectancy of more than 1 month. And then we need to be careful we remove pleural fluid more than 1.5 liter, there will be a risk of re-expansion pulmonary edema. And then for the intercostal tube drainage with a sclerosant agent instillation, this one will reduce the risk of recurrence unless you do in a setting of presence of a lung trap, then the lung is not fully expanded, then the risk of failed procedure is high. Then for intrapleural fibrinolytic like Hanafiya presented just now, it is recommended for the relief of distressing dyspnea due to multiloculated malignant effusion. So we will do this to lyse all the septation. For the thoracoscopy, it is recommended for the diagnosis, drainage, and also pleural disease of a non-malignant effusion. And then for the long-term IPC, it is effective in controlling recurrent and symptomatic malignant effusion. Then pleurectomy is rarely done. It is invasive with significant morbidity. So this is how IPC look like. We will insert it in the patient with a recurrent pleural effusion in case of a malignant post. So that's it from me. Thank you very much.
Okay, thank you very much, Ayas and Hanafia, for the very comprehensive presentation. Any questions from the participants? Anyone has any questions? You can type in the chat box, or you can unmute yourself to ask the questions to presenters and to our. Let's start the ball rolling. I have one question for Dr. Hanafia. In the case presentation just now, you mentioned that the pleural fluid biochemistry, the LDH was very high, therefore the chest drain was inserted right away, the patient. So just wondering what would you hands on the, I mean, is a chest tube insertion drainage routinely done for those with a high LDH or pleural fluid?
The indication for chest tube insertion in this case presentation, I'm not very sure because I don't have the case note in Queen 2, but as far as I know, for pleural effusion, we don't routinely do chest tube insertion lah, unless is memang empyema, so memang indicated for chest tube insertion, or maybe patient is very symptomatic also is not macam clear indication for chest tube kan, because we always can insert therapeutic tapping for the patient lah. But maybe if macam we do have macam plan for if pregnant pleural effusion, we do have a long-term plan for pleural disease or something like that, then there's an indication for chest tube for pleural effusion lah. But for pleural effusion, unless it's actually hemothorax or empyema, there's a clear chest tube insertion lah. The rest is not so sure. Maybe boss can help lah.
Okay, the Taufik here. Basically, pleural effusion is relatively easy to manage, but the most important thing that you should know, I think this is a very good question. The most important thing you should know is when to insert immediate chest drainage. So that's the most important thing. So there's a few indication when symptomatic and patient presented to you very symptomatic. I think it's no harm, always no harm to insert the chest drain, especially in a patient that you really think tapping won't help that much lah. The effusion rate is very high. So first, I think it's clear to insert if patient symptomatic. Second one, when there's evidence of empyema or impending empyema. If there is a pus in the pleural fluid content pus, is clear cut to insert the chest tube. But the problem is not all of our patients presented with pus. So that's the huge issue. So most of them presented with serous fluid. It's not really terbit pun. So that's the dilemma. So there's a multiple paper saying that how to indicate this impending pus, because when you have pus inside your body and the amount is huge, you know the patient can turn into sepsis anytime, and this sepsis can cause can cause mortality for the patient. So that's why when you have pus inside your body, anywhere inside body, you need to do drainage, you need to do IND everywhere else. And same like the lung problem. When you have a pus or empyema, and also the patient have impending empyema. So some of the papers said, most of the guidelines say clear cut pH you need to send. If it is less than 7.2, it's indication to insert chest tube immediately. So 7.2, but you need, I think Ayas mentioned just now, 7.2, you need to send for pH using ABG machine, not the standard one, because the standard one, they use litmus paper. So they can give you a decimal of no decimal reading. So they can give you reading like 6, 7, 8. So there is no decimal. So if you send via ABG machine, they can give you 7.2, 7.3, or 6.9. So if it is less than 7.2, indicate that the environment inside there is acidotic. It indicate it's impending empyema. Basically in empyema lah, the infection inside. So let's say if you know it's not feasible to do ABG, I mean pH immediately. So I understand some of the center, especially when we are on call. So some of the center, they already do tapping, but they cannot proceed with ABG because they don't have the accessibility to ABG machine. So some of the papers say you actually can use glucose. So you can send the pleural fluid for glucose and compare with your capillary glucose. So if it is low, less than some of them say less than 50%, some of them say less than 1/3 of the glucose is actually, and patient looks like in septic looking. So this is indication untuk chest tube insertion. So another one is sometimes some of the people say if you have high LDH, it indicates impending empyema as well. So that's why I strongly think this case was inserted because they are worried about empyema. So make sure, I think we all have the clear indication when to insert chest tube urgently, because towards the end, the most important thing is patient having a diagnosis. So and one of the diagnostic tool that we want to do usually is pleuroscopy or thoracoscopy, like mentioned just now. So and if you insert chest tube too early in non-indicated patient, maybe we miss that time window. I think we experience a lot of patient, kan? We drain a lot of pleural fluid using chest tube. Then in the end, we cannot proceed with pleuroscopy because there is no more space left. So that's why I think we need to clearly understand when the indication to insert the chest tube, and if there is no urgent indication to insert chest tube, you can do diagnostic tapping, and then we can work up from that. So another important thing is I want to emphasize, despite this presentation, on top of this presentation, is the lights criteria. So when you have transudative effusion in patient with pleural effusion, so when you have transudative, the lights is clearly described that there is no invasive investigation needed, further invasive investigation needed for transudative effusion. So if it's a clear-cut transudative effusion, you need to optimize the systemic problem. So try as much as you can to optimize the systemic problem if the patient have transudative effusion. Number 3, usually if you refer to respi for pleuroscopy, usually some of the patient we said that it's not feasible for pleuroscopy. So as you can see just now, how we did pleuroscopy, basically we need to introduce the trocar and also introduce the scope inside the pleural space. So that's why we need a space inside the pleura. So if the lung expanded or the pleural effusion become minimum, so it's quite dangerous to introduce trocar because the space is minimal and we are worried that it can injure the lung. So that's why some of the patient, we said that pleuroscopy is not feasible for this patient because I think the fluid become minimal. But other than that, if the patient have pleural effusion, we encourage if you already rule out all this infection, we encourage early referral to respi so we can do the pleuroscope early. So actually for me, I don't mind referring for ni, and we can do fluoroscope for early for unilateral exudative pleural effusion lah, after we rule out, especially after we rule out TB lah, because we will do the fluoroscope inside OT kan, so a bit close environment to our staff and a lot of staff there kan, so that's why all the pleural effusion usually we ask to send ADA first, then once we safely rule out TB, then we can immediately do fluoroscope for that patient. Okay.
Thank you, Dr. Taufik, for the answer and the explanation. There's one question in our chat box. In our APG machine, for example, the AM run pleural with pH or will it spoil the machine?
I'm not sure what is the brand AIM thing. I will look at. I never see the machine, but last time when we have our, I mean not here lah. I mean last time when I was in Alustar, we have our own ABG machine, and the syarat is you kena put whatever you kena buat how the way that you take ABG. So, I mean, you can heparinize the syringe and then make sure there is no sediment inside the pleural fluid, then baru you boleh run. Because I think the issue with ABG machine last time, the sediment stuck inside, especially the non-cartridge one. So if cartridge one is, you just can replace the cartridge with the new cartridge and you can run the ABG, but for non-cartridge that require calibration, everything, I think the best thing is not to have a sediment. You can grossly inspect the sample. If you don't have sediment inside the sample, I think should be okay to run just like any ABG sample. But make sure heparinize.
Would it be fair to say that if we already see frank pus coming out, then doing a pH is unnecessary?
Don't send. Okay, two things. If you see pus, clear pus, insert chest tube, don't send any pH anymore. So just send for CNS, workup for NA. And also another thing, when you see pus, don't send ADA because it will be high. It will be 1,000, it will be 3,000, and sometimes MKAK cannot read pun. So that's why that's two things. When you see pus, immediately insert the chest drainage and also send for infective workout, TB, everything. But don't send ADA and also don't send for pH because you want to look for empyema kan. If you want to send for pH kan, tapi this is a clear empyema. So don't send for pH and also ADA.
Okay, noted on that. Thanks, Dr. Taufik. Dr. Taufik has one more question on chest drainage. Since now we have so many detail and then rocket and many different sizes of chest tubes, which kind would be best suited for which kind of pathology? And empyema would you 38 or 32 French or B?
Okay. Your line is breaking. Tapi I think the question is does the size matter lah kan?
Yeah. And which size is best suited for what kind of
okay.
What kind of pathology?
Last time my my ex-boss, I mean my previous boss used to say the size the most suitable size is the size that the clinician comfortable. Kalau that clinician not comfortable to insert 32 French chest tube, then please insert the small one. As long as you insert and drain that thing, you can work out the rest after that. Tapi from the guideline, size does not matter. If you insert the small or large punya caliber, the outcome will be the same. But let's say you think this patient need further intervention? I mean, intrafibrinolytic therapy, like Hanafiah mentioned just now, kan? So I think we need something bigger, slightly bigger, to instill all those things and also to drain back all the fibrin and also all the breakage, the product. So that's why our rocket is actually size 18. So and so far we are doing well with 18, and I think most of us are very comfortable with size 18. Let's say if you all comfortable with bigger size, I mean not comfortable inserting the smaller size, please insert bigger size. And also most of the latest guidelines say, macam I think Ayaz already mentioned just now, most of the guidelines say when you want to insert the chest drain, there is no such thing blind technique anymore. All need to be ultrasound guided, because you know everything come with risk, kan? So all need to be ultrasound guided. I mean, it's a direct ultrasound guided or it's a partial ultrasound guided lah. You just mark, at least you know that location have the largest locule or largest effusion. Then either you tap or you insert the chest drain using that guidance from ultrasound. So if you ask me, kalau that night, I mean, especially during on-call time, during daytime, I think no problem inserting the large caliber. So during the on-call time, if you are not comfortable inserting size 24, size 20, or size 18, you can always insert the smaller one, size 14, even size 12. We have pediatric size 12, kan? As long as you drain the pus as much as you can, so that kita akan reduce the chances of patient develop sepsis.
Okay, thank you very much, Dr. Taufik. Anyone has any other more questions for this or for Dr. Taufik? Okay, if none, then I'd like to take this opportunity to thank Dr. Taufik, as a supervisor for today's CME, Dr. Hanafi and Dr. Ayaz, a comprehensive presentation. So I have no major announcements today. Anyone else? Any announcements?
Sorry, I got a Ku here. I got a question for Dr. Taufik.
Yeah, okay.
Right. Sure. I was wondering, let's say if the patient has a very massive pleural effusion causing a lot of respiratory symptoms, dyspnea and everything, do we still after we drain, let's say 1.5 liters and patient is still very breathless and everything, do we still clamp it and stop draining it, fearing the risk of expansion pulmonary edema and all? Or can we drain a bit more and all? Thanks.
Okay. Yeah, there's always risk of RPE, especially when you drain in the closed method. So closed method mean you connect that thing to underwater seal. It's different when we do fluoroscope. Sometimes some of the patient we drain up to 4 liters, but we are doing open method. So I mean, whatever fluid that we drain, it will be replaced by air. So they are not creating negative pressure inside the pleural space. So that's why when there is no negative pressure inside the pleural space, the lung is not expanding very fast. But the problem with closed method, the more fluid you keluarkan, the more negative pressure created inside the pleural space. So it will cause the lung to expand very fast. But you need to weigh the risk and benefit. Not all patients develop RPE when you drain more than 1.5 liters. So I think if we ask ourselves, have you ever seen RPE in front of us? Maybe one of two of you will say they are witnessing that. So it's a complication, but it's not that common. And also when the patient is breathlessness, especially the patient with massive effusion, and the fluid inside the lung is at least 4 to 5 liters. I think if you drain 1 liter, it won't make any difference. The patient will still breathlessness. So if you want to drain more than that, I would suggest you drain 500 and see the response. And then again, 500, slowly drain. Don't immediately drain another 1.5 liters and then left. So the rapid expansion too will cause RPE. The rapid expansion, the rapid release of fluid akan ni. So for me, no harm, drain and rest for 15 minutes or 20 minutes, and then drain again another 500 until the patient symptom improve. So 1.5 is just rough guidance for us. Even though sometimes some of the patient, you drain 1.5, but you drain it very rapidly. I think within 5 minutes, you can drain all 1.5 liter. Patient will develop RPE as well. So the 1.5 is not a safe margin also. So the rate is important. The rate for draining those things is important. You can drain 4 liters per day, but if you know how to control the rate, I think you can drain up to 4 to 5 liters per day. So that's why if you want to drain more, do it at the slower rate. That's my advice lah. So if patient still symptomatic, if you ask me to drain more, yes, please do it, but do it in the slower rate.
Okay, thanks a lot, Dr. Taufik. Bye-bye.
Right. Final chance for anyone who wants to ask any questions. Going once, going twice. Okay. Right. If not, if you have any other further questions in the future, feel free to always contact our SP team, the SPMOs who are taking referrals, trainees or SP consultants. I'm sure they will be more than give you guidance on how to manage patients. So we will end our session here today, and we will see you all again next week. So this will be posted to your groups as well. Thank you and have a nice day, everybody.
Thank you.